Okay, so this is me, Alex Menter, singing. I'm not singing right now. I will be talking about choral singing with COVID-19 in 2022. And I think the idea for this was simply that I think we're all having a hard time sort of readjusting to risks in the current environment with lots of people getting COVID and lots of concerns about what that means, but also lots of people being vaccinated. And so how do you put it all together when we're talking about a high-risk activity? So that's what we're going to run through and kind of lay out some rules for the road for how we think we should be operating for at least the immediate future. Next slide. Okay, so we'll go over some brief background, vaccines and therapeutics, individual risk. This is a thing that I think a lot of people don't know their individual risk, understandably, but because I think, well, anyway, we'll get into that later. But so we'll look at individual risk by age and vaccination status and that sort of thing. We'll talk a little bit about long COVID, future vaccines and future variants, testing, recommendations, and a summary. Next. Okay, so I am not an infectious disease expert or an epidemiologist, but I play one in clinic, and I'm kind of serious about that in the sense that I'm an oncologist, so I work with a lot of people who are immune compromised, and I'm also the head of my department at Kaiser, and I've been sort of part of the strategic response to how are we going to deal with this in the clinic. What are we going to do in our infusion room? How many people can be in there? Who has to be masked? What kind of mask? Like, what are the rules? So I have been kind of watching all the COVID literature. I've been advising my own patients about how to think about vaccines and how to deal with masks when they're immune compromised. I've had, I'll be honest, I've had a couple patients who died of COVID. I've also had many, many more who got COVID and recovered. So, I'm not a virologist, but I've seen a lot and kind of talked to a lot of people about their own risk. Next slide. And also just to say, this is not a talk about what happened in Guatemala. That was sort of a unique thing. We were overseas, we were eating together, we were on buses together. It's a little different than what we're doing in our normal operations. So if the board wants to talk about it, great, but that's not what we're talking about here. Next slide. Okay, just to say, these are some sort of level setting. There have been around 2 billion infections worldwide and over 6 million deaths. In the US, there have been at least 200 million infections, probably many more, and 1 million deaths. In Colorado, we had about 1.5 million official infections, so higher than that, and around 13,000 people have died due to COVID. Risk of death from COVID is strongly, strongly associated with age. I believe it's like around 2/3 of people who have died of COVID have been above the age of 65, and even amongst that, most of those people were in their 80s. Obesity, immune deficiency, cancer are also significant risk factors. And then in case, depending on how much news you absorb, I can tell you for a fact that, during some of these surges, the hospitals were, even in Colorado, in very dire straits, in the sense that, if you had a problem, you weren't guaranteed a bed going into the hospital. So that's real, and it's bad. If you need to go into the hospital because of some other for your cancer, you might not have had a hospital bed last January. Next slide. The other thing to say is that I don't think COVID's going away. I think there was sort of a contingency of experts that were hoping that it was, if we really laid it down and if the vaccines really worked, it was going to go away. I don't think it is. It's in animal reservoirs. It's evolving all the time. And our vaccines that we have are helpful at keeping us alive and out of the hospital, but they are not helpful right now at preventing spread, at least not very much. The other thing to say is that choirs now and forever are going to be a high-risk activity. We might not have thought about it as such 3 years ago, but in fact, we probably were getting exposed to viruses more then, too, than we thought we were. And I just think, that's going to be true now and forever, that there'll be a little bit of additional risk with choir based on what we're doing and all the aerosols we're generating. Let's see, what else do I want to say here? I also want to say there's some people that feel that why don't we just mask? It's not that big a deal. You can wear one all day. It's not that big a deal. Why don't we just go ahead and wear the mask to reduce risk for everyone? And I think I just want to say that there is a cost to it. There's a cost to not making as much emotional connection. There's a cost in terms of difficulty with communication. There's difficulty with emoting. There's a little, slice off the top in terms of how good our performances are and how many, vowels and consonants we can get out. So it's I don't want to say that masks are a huge deal, but they're a little bit of a pain, and they're a bummer, and so we want to we don't want to just say there's no cost to masks over the long haul. We want to acknowledge that they're not ideal, and that there's a trade-off. Okay, then I'll say that, let me look at time here. Okay, we're doing okay. There's a threshold exposure that you have to think about, and it changes over time. But, the first thing is sort of how much dose is there of the virus in the air, and then how much time are you exposed to that viral dose? And then also, what's your own personal immunity against that variant that you're being exposed to? So all those things are kind of constantly changing, and makes it very hard to kind of know in any given environment what your particular risk is, but we'll kind of get more into that later. And then we'll talk more about ventilation and circulation later. Next. Boy, I wrote a lot on that, and it's really small. Okay, so let's just, I think I said it already, but I'll say it again here. The vaccines have been, even though we're kind of disappointed that we can still get sick now, they really have been miraculous in terms of saving lives, and also helping the hospitals. And when I think of the last surge in January with Omicron, and the hospitals were being overwhelmed, most of the people who were being admitted to the hospital at that point were still people who were unvaccinated. So now if you look at the numbers, it's closer to 50-50. And what a lot of hospitalists and other people will tell you is that the people who are coming in are older or immune suppressed. But the vaccines are still working quite well at preventing the worst outcomes that we worry about, hospitalizations and deaths. Yeah, go ahead. Totally. I mean, I think the CDC set out some, expectations hoping that it would reduce risk of transmission or death by like a third. And because that's kind of what they were seeing with the flu vaccines. And then I think what happened is the vaccines came out, initially it was like 90%, and no one was getting sick after that. And we should have known better, but I think we kind of thought, oh, we're out of this. This is awesome. It's done. Just get your vaccine and we'll all be okay. And then, vaccine misinformation, people resistant to vaccination, and then of course, the virus kept changing. So the initial rules that we thought might have gotten us out of the pandemic turned out not to be true. But you're absolutely right that the vaccines actually are still performing quite well relative to our baseline before we started giving them. In terms of what we were hoping for. The other thing to say is that a lot of people are now have what we call hybrid immunity, meaning that you've actually seen the virus and it's been in your body, and you've developed additional antibodies against non-spike protein parts of the virus and the core of the virus, in addition to what you got from your vaccine. So that's hybrid immunity, and I think it's pretty clear now that if you have hybrid immunity, that gives you additional protection. Again, not that you can't get infected, you may, But in terms of serious outcomes or more severe illnesses, that hybrid immunity is really important. I don't know if I talk about this later. There is talk that there's going to be, the CDC and FDA are hoping to have updated vaccines for the fall that are going to be targeting the Omicron 5 variant. So we're hoping maybe those will be a little bit better at preventing spread. And there's also people looking at like nasal inhaled vaccines because that's where the virus is mostly getting in. And getting a vaccine in your arm, you don't get as many antibodies in your nose or throat. So they're thinking maybe if we can do some vaccines that are locally delivered, we can build up those antibodies in our nasal passages and hopefully have a better chance of preventing any infection. Next. Sorry, taking a breath. Okay, you don't have to read this. I'm just saying this is New England Journal. Next slide. And this is looking at hybrid immunity. And let's see here. So this is out of Qatar, and this was in the news recently. And if I'm remembering correctly, I think this is 3 doses of vaccine, and this is up here in the upper right-hand corner. This is preventing serious infection or hospitalization or death. And if you had hybrid immunity, like 3 vaccines plus a previous infection, it was like no one was having really severe outcomes. But if you've only had the vaccine, it wasn't quite as good. Oh wait, here it is. 2 doses of vaccine. Sorry, this is 2 doses. This is 3 doses, still quite good. This is 2 doses plus infection. This is 3 doses plus infection. So anyway, that's just kind of illustrating that this hybrid immunity is helping. Next. The other thing that's new within the last, let's call it 6 months, is therapeutics. I mean, there were some what we call monoclonal antibodies last summer that were given out, but it was really difficult to get monoclonal antibodies because these are all very infectious people, and it's hard to find clinics that can accommodate people who are actively infectious. And then they were having a hard time making enough of the product because they're hard to manufacture. Now we have Paxlovid, and there's a few other medications too, but Paxlovid is one of the big ones. It was approved in December, but it really wasn't available to most people until like February, March. There might have been a few people who got it, but it was really hard to get your hands on early on. And again, this is a 90% chance of keeping you out of the hospital, 90% less risk of death. Hasn't been actually, it was mostly tested in people who were unvaccinated, so the data was pre-vaccination, and there are some people saying, maybe it works a little differently when you're vaccinated, and that's why some people are getting rebound, but it's still an extremely good drug. And the other thing is that it's in ample supplies right now. So if you were high risk and you got COVID, you can get it, okay? And you can pick it up at a pharmacy and then go home and take it. Okay, what else do I want to say here? Don't need to worry about. Oh, and the other thing is for people who are immune compromised, a lot of my patients, there's now this monoclonal antibody called Evusheld that you can give it. It's like a 6-month protection. So it kind of slowly releases antibodies into your system for 6 months against COVID. Also, prevented 80% of infections and very effective at keeping people alive and out of the hospital. So for people who are worried that they're not responding to the vaccine, people on chemotherapy, people with immune compromising conditions, they can get that Evusheld, and that's providing for some protection as well. Next. This is the Paxlovid data. I guess I'll just say, notice that the scale here is on the far left is 0 to 100, and so this is the actual risk of landing in the hospital or dying is the blue bar without Paxlovid, and then the orange with, and then they blew it up here so you could see it more easily. But most people getting COVID are not landing in the hospital or dying. But there is still a difference, and it was a big study, and it did show that, yeah, it works to keep people out of the hospital and keep people alive. Next slide. This is the same thing basically with that Evusheld I was mentioning, which is pre-exposure prophylaxis, and we're using it in the US in people who are immune compromised. Next slide. Okay, this is absolute risk. And they kind of give you bands of certainty because there's always uncertainty in these things. So let's just look at the kind of best guess in the middle, the 50%. And so this is you can go online. I put the thing here, but you can kind of say, okay, I'm a healthy 32-year-old woman, and I've been, vaccinated and boosted. What's the chance that I could die from COVID if I get it? And what I want you to see here first is that it's out of 100,000 here, okay? So before you got vaccinated, you had about a 7 out of 100,000 chance that you could die of COVID. And there were people in their 30s and 20s who died of COVID. After your vaccination, now you're at 0.72 out of 100,000. Next slide. Okay, now we're up to almost my range, 50 out of 10,000. Okay, so you notice that as you go up in age, this denominator changes kind of logarithmically as we go up. Next. Okay, 65, high blood pressure. This is out of 1,000, so without vaccination, 2 out of 1,000, or 1 out of 500, if you want to think of it that way, and now it's 0.21 out of 1,000. Next. Okay, now we're getting higher risk. 78 years old, obesity, maybe they've got prostate cancer, and now we're out of 1,000 or 1 out of 100, but with vaccination, it's closer to 1 out of 1,000, okay? 85-year-old male with dementia now. Now we're out of 100. So initially it was like 2 out of 100 people would die, which actually, surprisingly, some people might say that might be an underestimate because I think it was maybe closer to 20 or 30%, in some nursing homes and people who are real old. But at least based on this calculator, still getting a significant drop in your risk with the vaccine. Next. And this is what we're seeing in the world in terms of COVID deaths. So even though our case rates are real high, this is as low as we've been in terms of deaths since this all started. So we're in a different situation than we were last summer, and certainly different than when we were all isolating kind of early on in the pandemic. Next slide. Long COVID, I think there's a lot spoken about this, and it's not as well understood as we'd like. They're about, and there are different definitions of what it is, but it's around 10 to 20% of patients that may have symptoms that persist beyond a month, okay? And it's more common in people who are unvaccinated or if they had a real severe infection. So if you landed in the hospital in the ICU and were on a vent for a week, you have a pretty high chance of long COVID. But I will also say some of that's just being sick and in the ICU. So people with, regular old pneumonia, non-COVID, if you were in the ICU for a week, it would take you a while to recover. So some of this is just kind of general illness, but I do think that there's some specific weird stuff with autoimmunity. There's people with brain fog. There's other things that can happen. Well, let's go into the next slide. Too small, sorry. This is a New England Journal paper on long COVID. And they're talking about like how many people were having fatigue, and they said 15 to 87%. That's pretty long, and that was 3 months or longer. Chest discomfort, cough. How many people had cough? It took 2 to 3 months to improve if you had a bad cough for long COVID. Loss of smell. That was around 10%, and most people were clearing by about a month. Some people had joint aches, headaches, poor taste. That's less than 10%. And then there's some people with kind of impaired memory, anxiety, other things like that, usually clearing within months. Next slide. And then these were some of the risk factors. Long COVID's a little more common in women, more common as you get older, more common if you're overweight. But look at this. If you've been vaccinated with 3 doses, you're about 80% less likely to get long COVID. So that immunity is helping. Next slide. And the other thing to say is there's some alarmists about long COVID that feel like society will implode because everyone will have long COVID and can't work. And I guess what I would say is that so far we're not seeing an increase in disability claims in the US. It sucks, and maybe they feel off for a bit, but they're going about their lives and they're going back to work. So we aren't seeing a rise in disability claims yet. Okay, next slide. already kind of went over this. They're working on pan-coronavirus vaccines. They're working on nasal vaccines. They're working on updated variants. The variants are coming about every 3 months, though, so it's going to be a little bit of whack-a-mole. And frankly, there's a big question mark, even if they have an updated vaccine in the fall against Omicron 5, is whether or not we'll still be dealing with Omicron 5 or something else. And so we don't know. But anyway, it's still, we're still have our hybrid immunity, and hopefully it won't change that much, because I keep holding on to this in my head, and I don't know how true it is, but there's this enzyme that it sort of latches onto called ACE2, and you can't mutate so much that you can't attach to that. So yes, it can keep mutating, and yes, it can try and evade our immune system, but it can't mutate so much that it doesn't attach to that enzyme in our lungs. Next slide. Oh, okay. Well, this is just sort of the state of my knowledge up until Guatemala, even though I was ignoring things a little bit. Okay, next slide. Okay, and this is to go back and say that, and I think I had heard of some of these before, but I was kind of personally ignoring them. But this was Norway in November, December. There was a holiday party, and everyone was encouraged they all had to be fully vaccinated, and then they were supposed to do a rapid test before they came. And what happened is everyone went to this Christmas party, and 74% of the people got COVID. This is when Omicron came, okay? So, but basically what that says is, sorry, the tests don't necessarily protect you 100%. Next slide. And this is intercollegiate athletics, where they were doing daily testing for all these athletes, and also, again, showing that even when you're doing daily testing, even when it's negative, it's still breaking through that sometimes. And then, of course, I read this while I was in my hotel room in Guatemala, and this is June 10th. So anyway, I don't know if we would have done anything different if I had or if we had all kind of read that and thought about it. But anyway, the point is that there are people who are getting some symptoms, and some people are relying on a negative test, and you probably shouldn't rely on a negative test, okay? So lesson learned. Okay, and this is, again, me. I had a scratchy throat for a few days in Guatemala, and I kept testing. I was like, I should be okay, it's negative. And again, in retrospect, pay attention to your scratchy throat. Next slide. Okay, so this is a framework for considering policy for the choir. On the one hand, we're balancing individual risk for COVID and COVID complications versus the individual need for human flourishing. That's the word I like to use. Here we go. And then there's also creating a safer baseline environment for us all to get together in and sing in. And then the other question is, when do we have a responsibility to the community to help reduce case rates? So I'm going to go through those a little bit individually. Next slide. Okay, so at base, I would say this. In general, you have to assess your own risk, and you have to kind of understand, what risk you're comfortable with, and then, and that's based on your health status, your medications, your age, whether you're fully vaccinated, and then also who are you exposed to at home. Now, we've been through this a couple times now. It is possible to get COVID and not infect housemates, but it's a little lucky too. If you don't catch it in time, you absolutely can infect everyone in your household, but if you catch it in time and if you get a little bit of luck, you can not infect housemates. But nevertheless, I do think you should be considering the people who you are in regular contact with at home in terms of your personal risk. And here's the thing. So as you look at your own risk and your family cohort, you can choose not to sing. That's an option. And for some people, that may be the right option for the time being. And you can also, I still believe that good N95s and KN95 masks are not 100%, but let's call it 80 or 90% protective. and you can choose to wear a mask on your own. So that's sort of your individual responsibility. Let's go to the next slide. This is considering what we should be doing as a choir to reduce our risk that we all get sick when we go to rehearsal. And just talking about, okay, so this here is a CO2 monitor. If you're in a small room with a whole bunch of people who are talking, the CO2 is going to go up. And that is a surrogate that is sort of associated with aerosols if someone happens to have COVID. Now, if you have high, if everyone's wearing good masks, and if there's air filtration in there, maybe you can get rid of those viral particles, but the CO2 will still be high. But as a baseline, the CO2 tells you how much air circulation is, what's the air volume, how many people are in that space breathing. And you can kind of, like if I go outside with this, it's going to be around 400 to 410 parts per billion, whatever it is, or ATMs, whatever. I don't know that. Ask the physicist. Anyway, most people will say you want to keep it ideally less than 800 and hopefully less than 1,000 for good air quality to kind of say you have reasonable air circulation. Last week I was tickled because we were having a hard time getting this up to 500 while we were singing. So I think that speaks to the size of the room and that there's pretty good air circulation in here. So yay, we're going to keep testing. We're going to get some additional CO2 monitors. They're going to have the fans going on in the church to help make sure that the air is circulating. But that, I think, reduces your risk of having a super spreader event. So maybe if the person right next to you singing in your face is sick, you may still get infected. But I think the chances that 45 out of 60 singers get sick, which is important because getting sick sucks. Okay. Okay, now, this is one I was kind of struggling with, which is, what about when community circulation is really high, as it has been here recently? And what I would say is, it's kind of, at least in my mind, it's kind of like thinking about the weather. If someone says that there's an 85% chance of a torrential rainstorm with lightning, are you going to wear a rain jacket? Okay. And the answer can be no, but I might wear a rain jacket if I know circulation is really high. Now, how do we determine what circulation is in this day and age? Because most people are testing at home. And at least my answer is we should be looking at wastewater, which is really exciting. So anyway, used to be if you were getting all your tests through PCRs in the state, it was pretty reliable. We knew how many people were getting sick. Now we're off by a factor of 10. But wastewater kind of tells the story of how many people are infected in the community at any time. Next slide. And this is wastewater for South Platte, which includes where we're at now. And they get pretty good data, and they usually put in 2 measurements per week. This here is the Omicron surge last January. I mean, just massive. You can see how many people got sick, and it was all Melissa. And my kids, actually. And then, this is kind of where we've been. So, but I guess look here. Look how high this is what the official case rate was with Omicron in January. And now look at the case rate over the last few months. And then look at our wastewater. It's a lot higher. Like, this tells a better story for how much COVID there's actually been out there recently compared to the actual case rates. Now, that being said, there are some people who abhor masks, or they have a really hard time breathing or singing in masks, or they feel claustrophobic in the mask. To me, if you're one of those people, even if the circulation is high, I don't feel like we should be twisting their arms and forcing them to wear masks. I feel we can recommend it. Maybe most people will wear masks if we're really high with our circulation, but I also don't think we should, necessarily need to require it with high circulation. I think it's just a recommendation. And by the way, so I took the screenshot a couple weeks ago. The last measurement was around 400. So it's been coming down. So at least that's part of the reason why we're not wearing masks now, or at least not recommending them, is because it has fallen above that sort of threshold that we were looking at. Okay, and then the last thing to say is that if the hospitals are in trouble, I think we have a obligation as a community to protect those hospitals, so that if you get sick with something and someone needs to go into the hospital, that there's a bed for them. And so if the hospitals are in trouble, I feel it should be mandatory to mask. And my guess is that maybe public health officials may say that too, but I think we could draw that line ourselves as well. And I don't know exactly where to draw it, but I said there's no perfect cutoff, but if there's over 1,000 patients in the hospital at any given time in Colorado, that might be a time to say that we're going to do mandatory masking. Next slide. So that level's about here. If you actually look at the dates here, we would have been mandatory masks from about October through about February, if you were looking at how high that was during those recent surges. And this is where we're at now. I mean, the hospitals are doing pretty good right now. So even though there's a lot of COVID in the community, we're in pretty good shape. Next slide. Okay, performances. Testing is not 100% reliable, but actually, Emily, you tested and felt fine and had a positive, however long ago that was, right? So maybe occasionally you catch one. Frankly, it's cost prohibitive to do it for every rehearsal, but I think it's a reasonable step to take if we're going to be unmasked and singing performances, both for us, but also for our audiences and other artists that we're working with. So I think it's in the plan to continue to do antigen testing before we do, concerts and those sorts of events. If you want to mask during a performance, go for it. Now, here's the thing. If you feel sick, even if you test negative, don't perform. And here's where I think this is a tough call. Like, I did not feel sick in Guatemala when I had a scratchy throat. I thought it was just air pollution or screaming too much at the party. So it was not, I would not have called it a sore throat. But I think if you have gray area symptoms and you're tested negative, wear a mask, okay? It doesn't mean you have to stay at home, but wear a good, high-quality mask if you have any symptom that you're wondering. Could be a headache, could be, God, I feel really tired today, or is that, or a scratchy throat. Wear a mask. If you feel sick, like, uh-oh, that's a sore throat, or I feel, something's off, don't perform, stay away from us, okay? If you had an exposure at home, you may not, get sick, but, please mask for at least 5 days, okay? Because just to be safe, and then test before you come back. We already talked about this one. And then this is just the statement that on average, for average risk, hospitals are okay, average community circulation, we think it should be okay to perform and practice without masks. Next slide. This has been hard for everyone. COVID is real, and over 1 million people have died in just the US because of COVID, and a lot of other people have health problems as a result of their infection. Things are getting better, in part because of vaccines, and also because we're building up natural immunity from infections. Oh, I'm sorry, I'm going over. Choir will never be zero risk. We think that there's a real cost to wearing masks long-term, but we embrace individuals' choices to either not sing or mask if they want to. Next. And we already kind of went through that. We can send these slides out. But these are all things that I just sort of said. We're just trying to summarize it. Next slide. Is that it? Okay. Any questions for me? Okay. If you have questions or concerns, feel free to reach out to me
So this will be
individually.
online, and we'll
Yeah.
also send out the slides. And so, and I'll give you Alex's email address as well for any ongoing questions or concerns. Thank you, Alex. What a great job.
Sure.